My name is Chris Cheney. I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Battling the Burnout, sponsored by the American Medical Association. Thank you to our sponsor for making today's program possible, and to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right side of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists for today's discussion. Jim Gilligan, Vice President, Health System and Group Partnerships at AMA. Nigel Gergraw, Chief Wellness Officer, Ochsner Health. Chris Pomrink, Vice President of Medical Affairs at Virtua Health. And Sapna Singh, Chief Medical Officer, Texas Children's Pediatrics. Thank you all for joining us today. And with that, let's get into our discussion. First, please tell us a little bit about yourself and your organization. And Jim, why don't you start us off?
Great, thanks so much. Jim Gilligan, I'm with the American Medical Association. The AMA is the largest physician organization in the nation. We are responsible for shaping policy, supporting clinical practice, and advancing public health. My team at the AMA works with leaders from large healthcare organizations to make sure that they have tailored solutions they need to enhance support for their physician.
Nigel?
Yeah, Nigel Gergraw. I'm a practicing transplant hepatologist working at Ochsner Health, which is a large health system based in the Gulf South. We have about 40,000 employees, about 5,000 physicians. Originally from Canada and moved to New Orleans in 2007.
Chris?
Hi, Chris Pomrink. I'm an internist hospitalist. We're at Virtua Health in New Jersey. We're a 4-hospital system, roughly about 16,000 employees and over 3,000 credentialed medical staff and medical group members.
And Sapna?
Hi there. I'm a pediatrician with Texas Children's Pediatrics. I'm also the Chief Medical Officer and the Medical Director of Physician Wellness for the organization. We are the largest primary care pediatric group in the country with over 66 clinics in 3 different cities throughout Texas, Houston, Austin, College Station, and very happy to be here today.
Excellent. Let's get into our discussion. How can healthcare organizations, oops, I think I might have missed a question here. Oh, no, that's the first one. How can healthcare organizations remove the stigma associated with mental health from physicians? And Jim, why don't you start us off?
Thank you. And it's an important question, an important discussion. I think I'd start by saying it's really important to move from a culture of silence and shame to one where it's okay to not be okay. And I think that responsibility really falls on senior leaders from groups that employ a lot of physicians to really set that culture. And I think a great example of doing that is sharing their own personal stories of mental health issues and struggles. I think that's a great way to do it. And I'd say another thing that we're a big advocate of at the AMA is, removing some of the invasive questions regarding mental health when it comes to credentialing. A lot of groups will do and offer a lot of resources to support mental health, but physicians are avoiding that or afraid to use those services because they're going to be asked questions about those later, especially when applying for privileges. So that would be where I would start to answer that question.
Great. Nigel, why don't you go next?
Yeah, sort of a similar response to Jim. Before the pandemic, I didn't really want to talk a lot about mental health because I didn't want to conflate mental health with burnout, the occupational syndrome. Obviously, it became very important during the pandemic. I think one way, as Jim spoke to, is sort of normalizing the discussion. You can do this in a number of ways, but that's, I think, largely leadership behavioral norms. The first summer of the pandemic, I was struggling with depression and anxiety, and I sent an open letter to all employees at Ochsner, talking a little bit about my struggles, but more broadly, the stigma around mental health that exists. And that was a very well-received email. And another way is this past February, we removed intrusive and stigmatizing mental health language from our credentialing, re-credentialing, and peer reference forms. We had about 9 questions that we altered the language significantly.
And Sapna.
Just to build on what has already been said, I think being a part of the discussion and making sure that people are aware that they should not have any fear in being able to discuss their own struggles or to reach out for help when it's needed. And that really it comes from leadership and goes through the system, because if the leaders are willing to have those discussions and bring this topic up in conversation, it helps people open the door to be able to kind of communicate back what they need. We also are fortunate. We have removed all stigmatizing questions from our credentialing and followed actually the roadmap from the Lauren and Breen Foundation to become a well-being first organization. And I think that's very important, because not only is removing those questions from our credentialing processes and to be license renewals and other different applications that we all have to deal with important, but it's raising awareness that when that has happened, it's an active effort by that organization to really welcome the conversation and to not shy away from it when it does come up. We are really good at compartmentalizing how we feel. It's part of our training is to, see something and move on because you've got another patient to take care of. But when the patient is us, we've got to be able to show people that don't compartmentalize that part of your own well-being. You've got to be open to that discussion.
And Chris.
Yeah, I agree with all the panelists. I think talking about it, the more we talk about it and weave it into our conversation and our meetings, it takes away that stigma, that boogeyman, if you will, the more we talk about it. One of the things, as a tactic to help with that, at each of our MEC meetings, we have a wellness tactic or wellness initiative, and really training our physician leaders how to share their stories and how to share their struggles with burnout or depression or those types of things. Yeah, a lot of power comes from vulnerability. And I think the more our physician leaders get comfortable, the next step is them bringing it down to their departments and, having a wellness check within their department meetings. And so, again, permeating the language and the discussion, and that it is a very real concern amongst physicians across the country. And the more we talk about it, I think it loses that stigma, and, we get more support and more people willing to open up about it.
Excellent. What are the primary elements of a wellness program or committee for physicians? And Nigel, why don't you start us off?
Yeah, happy to. We used the Joint Medicine framework to sort of build our office. So I think firstly, you have to resource the role. It can't be a 0.1 FTE. I've 60% of my time set aside to lead our efforts. You have to resource the office. Secondly, you need to commit to measuring the state of burnout and drivers of burnout. Another important component is to develop leaders, because probably the number one driver of professional fulfillment is the perceived quality of the one over leader. You have to commit to practice efficiency in a number of ways. And also, you have to have a peer support program in place. So those are, I think, fairly important components for building a well-being program.
Chris? I think we might have lost Chris temporarily. Hopefully we'll get him back shortly. Sapna, why don't you go next?
No, I think that fundamentally what I have found is really important is buy-in, and it's really having both leadership and physicians at the table. I think many times programs with the best intentions are put together, but without the buy-in from the folks who really have the influence to drive decision-making and change. And so when you're putting together a wellness program or a committee, the physicians being active members, being engaged is very, very important. But fundamental to that is also having the ear of somebody in leadership who has the ability to actually move the needle on the things that need to be worked on at the system level. And I agree to echo the Joy in Medicine roadmap. That is a strategic plan that every organization can look to standardize what their tactics are for trying to address those system level issues. And then at the end of the day, take action. We can survey and we can assess what the needs are and what people are asking for. But if we don't take action, you don't build trust. And many of the programs that, again, are started with great intentions end up kind of fizzling out because at the end of the day, nothing really happens from what they're trying to work together to collaborate on. So I think having buy-in at the leadership level is fundamentally crucial to getting these programs off the ground.
And Jim?
Yeah, I echo what my fellow panelists have said, and I know Dr. Pomerich's back, and I'd like to hear his opinion on this, because all three of my panelists are recognized in the AMA Joy in Medicine Health System Recognition Program. So if you want to talk to three people about putting together a great wellness program, they all three have proven to be able to do that. I would just echo, though, again, what Dr. Giergrau mentioned, which I think it's so important to have an executive who is leading the well-being committee, somebody who has a budget, has the ability to have accountability assigned to them, but more importantly, has influence with the rest of the leadership team to be able to make the changes that are necessary in order to improve physician well-being.
Yeah, Chris, I'm glad to have you back. What are the primary elements of a wellness program or committee for physicians?
Yeah, I agree. It's getting the right people at the table and the right people on the bus, if you will, right? It's the people who do the work, who know what the pain points are. But I think to Sapna's point, it's also the people that have the impact to make changes. As Jim was saying, the people who have the budget. And it's not just the organization. Our medical staff, through our dues and all these other has resources as well. So they're committed to being a part of that. So it's your CMO, your physician leaders, people who have budgets, but also people who have a passion for this work. We need their commitment to raise the concerns and bring to light some of the opportunities that we're missing. But make sure we're also not missing segments of the medical staff or the groups we serve. If we don't have a hospitalist on the committee, then we're missing a significant avenue, or a radiologist, or anyone, a proceduralist. So making sure we have the right people on the bus. We identify those areas, and I think Nigel was kind of touched on. We look at it as two different components: the clinician support committee, where those clinicians who are struggling right now, who are having some challenges, that we have some additional resources we can wrap around them, some additional services. But then there's how do we, take care of those while we're also promoting wellness and enhancing wellness. So we also have that wellness component in a wellness committee.
If I can just add, these are all great points, but Organizations can be impatient, physicians can be impatient, but it's important to put, structures, processes, programs in place, establish metrics. Obviously, the primary metrics are going to take years to change, like engagement, reduction in burnout. Process metrics, are the programs you're putting out there being utilized? Do they have high net promoter scores? And then secondary measurements like pajama time, things like that. So you just have to be patient, but act and put those structures and processes in place.
Excellent. Let's move on to the next question. What are the primary elements of a wellness survey to gauge physician well-being? And Chris, why don't you start us off?
Sure. We utilize the Stanford survey, and that's been serving us well. We've been utilizing that for 3 years. It's a well-known, validated survey. So, the questions on that survey really center around wellness. How well are you? How satisfied are you with your work? Happy, satisfied. Do you use words like worthwhile? Do you have control of situations? Meaningful? Then it also breaks it down into burnout. Are you unsatisfied? Sense of dread. I know many of you are familiar with that survey. And then, but we also add another additional components before we send it out. Really gauging demographics. How old the clinician is, how long they've been in practice, what's their gender, where they practice, what their specialty is, because not everything we think about wellness, not one size fits all. So yes, we can focus on, in an inpatient environment, but we also have to concern about the outpatient environment, ambulatory environment, or proceduralist versus non-proceduralist. So we're trying to dig down where are the pain points, and what we've noticed is some from that survey is, our primary care physicians were struggling. So we're really focused on them over the past year or two. But we're also using other strategies that we're gleaning that information from, the quantitative data, but also the qualitative, what we're getting from the comments. The comments are so important to driving our goals and how the wellness committee is going to focus on the next year to come.
Sapna?
Yeah, I think that, having a wellness survey that has been standardized, we've actually used both the Wellbeing Index survey through Mayo as well as the Press Ganey, and are moving towards the AMA org biopsy, in the future. It's important to make sure that those questions that you're asking are getting to the root cause for a lot of people of what is driving their burnout. And then I think that, to build on that, it's the idea also of sharing these results system-wide, and that everybody has light on the answers to these questions, from leadership to the front lines, clinical, non-clinical staff. I think that it's so important for people to understand what is my responsibility in not just helping with the intervention, but what piece of this am I potentially contributing to as well? And that's helpful, because then when we make decisions from a different frame of mind, as far as, well, that showed up on that last survey, I've got to think about whether or not we want to do that again. It really does help sometimes to change the conversation. And I absolutely agree. When you look at these surveys, I don't know that you can boil the whole ocean at one time when you look at the answers as they come through, but picking at least those top 3 or 4 things and building your strategic framework around, let's tackle a couple of these. As I said before, for me, taking action is fundamentally important. So we'll pick some low-hanging fruit I can do something with right now, and then we've got the bigger projects that we're going to strategize around. So really important to kind of take action on what you do ask about.
And Jim?
Yeah, I loved what Dr. Pomerink said about that opportunity to combine the quantitative data and the qualitative focus group information you might get, or the comments from your survey. I think the numbers will tell you what's wrong, but the stories are going to tell you why. I think that's just such a cool opportunity to be able to combine those 2 data points. I'd also just say a key part about your measurement strategy should be the type of survey you're using. I totally understand that survey fatigue is a real thing, but I've talked to so many leaders that are counting on engagement surveys to also help them with their tactics around reducing burnout. And I just think that that's a really risky move. it's entirely possible, and I think very common, for clinicians to be highly engaged yet deeply burned out. In fact, I think the most committed to their work are often the ones that are most at risk when there's systemic pressure mounting on them. And so I just think making sure that a group is using a validated well-being measurement tool, whether you're using what Dr. Pomerink's using at Stanford, or the Well-Being Index, or the AMA org biopsy, it allows you to look upstream at some of the things that drive professional fulfillment, but also allow you to be ahead of the game and identifying things that could be providing risks later on for your physicians.
And Nigel.
Sure. We've used the AMA organizational biopsy 7 years in a row. The KPIs that we follow are burnout, job stress, job satisfaction, feeling valued by the organization, and intention to leave the organization. But as all the other panelists pointed out, you have to also look at drivers of burnout, perceived culture, perceived leadership, perceived equity in the workplace, sense of workflow optimized. And we certainly benchmark against ourselves year over year, but also against national results. And as others pointed out, it is critical that you cascade the results down quickly. And we're trying to put a little more rigor around this process, where our department chairs have to discuss their results, and they have to develop an action plan. And it's not 10 things they're going to focus on, it's just one thing that year. And then, like the others said, the qualitative feedback is equally important. So I read every comment that comes back on the surveys. Yeah.
And we've talked about this a little bit in the first question on this topic of a wellness survey, but how can a wellness survey drive physician burnout interventions? And Sapna, why don't you start us off?
I think fundamentally, being able to expose what are the factors that are leading to, people's burnout is how you start to build your strategy around what do we need to fix. I will say I have not seen on a single survey that people are missing out on cupcake parties or pizza parties. That has not shown up, surprisingly, on a single, comment. But what has is, being able to manage their efficiency in the clinic without having to be in front of a computer screen the entire time. Being able to access certain resources to help offload work that is unseen, such as prior authorizations, for example, or the multiple calls to try to get a patient in for a certain type of referral. So there are things that are revealed in those surveys that you can start to look at, and there's themes that will arise. I think that when you look at the comments in particular, and I would say it behooves all of us to ask hard questions, and ask questions that sometimes are really difficult to read the comments about, because you get some insight into things that aren't going very well. And that sometimes can feel like it's an attack on the system or on the leadership or the folks that are trying their best to do a good job. But it is also an opportunity for us to take a look and say, okay, what do we really need to change? Either there is an action that needs to be taken to fix this, or there's a perception that exists out there that we've got to correct as well. Because many times it's just a lack of awareness about something that may exist as far as resources. So really just taking a hard look at those themes, those topics that are arising, and being thoughtful about how do we start to strategize around that. And that's where your wellness committee and then the collaboration with leadership really start to take effect.
Jim?
Yeah, again, I want to make sure that my fellow panelists have more time on this, because they're actually doing the work and using these surveys to direct change. But I would just say a couple recommendations is make sure that the insights from your survey feed directly into leader action plans, and are something you look back on when putting together your organizational strategy. Because I do believe that well-being has to be part of the overall strategic plan and not just a passion project on the side. And so going back and staying anchored to the insights from these surveys, I think is really crucial.
And Nigel.
Yeah, I thought Sapna had an excellent answer. Another thing is you have to communicate the results, as I said, and you can't have leaders think of this as a referendum on their leadership. So there has to be a sort of a willingness to speak openly about what you're finding on the survey. I'll also add that it will also give you an idea about where to most urgently deploy interventions like ambient listening. So, we've seen much higher levels of burnout in our primary care physicians. So that's where the urgency was to intervene. Other things that we look at are vacation utilization. That's a simple one, or you'd think would be a simple one to correct. Are your physicians taking their vacation? If not, what are the barriers to taking their vacation? So a number of things, but I think directionally, the survey will tell you where to go and where to go first. And then, as Sapna also said, you have to communicate, you said it, we did it, because sometimes there is survey fatigue and there's been some learned cynicism about if you're going to act on the survey.
Yeah.
And Chris.
Yeah, I agree with my fellow panelists. I think the survey is great. It tells the board, and we present our information to the board of trustees and our MECs and our local leaderships. It tells why we need to take action. And then all the results tell what we're going to do or how we're going to do it. One of the things we recognize is communication, where we think we're communicating from the executive level, the senior leaders down. Are we meeting the needs of the physicians who are doing the work, where they're doing their work, and not making it more complicated? So, a couple of things that we realize, we have to figure out different ways to communicate and connect with our physicians. And, whether it's having town halls with corporate leaders as well as local leaders, having a discussion, maybe no formal agenda, but having a discussion. Maybe we're talking about wellness and really having more face-to-face connections, because in this digital world that we're all on now, it's a lot easier to have a Teams meeting, but making those personalized connections and the communication piece is so critical. And then again, this is all information we're getting from our survey.
And are there other communication strategies, beyond town halls when it comes to sharing the findings of your surveys?
Yeah, from my standpoint, yes. I mean, we work with our marketing team. We have a clinician, email, newsletter. We cascade it down into our MEC and into our departments, and then into our employed medical group. So there's those typical channels. We're looking for other different channels as well, such as, certain areas of the hospital where physicians frequent, posting them there, posting updates that are short, sweet, and just what physicians need to know, or adding QR codes if you want to learn more. So really looking at our communication channels is really an important driver for us right now.
We're lucky we have somebody from internal communication sort of embedded. I think it's very important that you communicate well. As others have mentioned, I've understood the power of storytelling rather than just sort of, the usual sort of corporate email. Making sure that, and this is the other good thing about having somebody from internal communications with you, they know when other things are going out in the organization, so you don't want to send a communication out that's competing with 10 other communications that day.
Just to respond, Nigel, I think that's a key important point of this, is having your marketing team, your internal communication team help facilitate any type of wellness initiatives, because it is important to get that out there.
Yeah, if I could add to that, because Dr. Girgrah made a really important point earlier, which was you can measure and you can start fixing things, but those fixes take some time. And physicians aren't always patient about that. But I think, because of all three of these panelists have been recognized in the Joy in Medicine program, that's something you can communicate to your physicians too, if that's something you've been recognized in, because it doesn't mean that everything's fixed. It just means that you're following an evidence-based roadmap and that you have a plan in place and you've demonstrated that you're following that plan. And so I think that, something that has a credibility like a program like that, to be able to show your physicians, hey, we've got a roadmap and we're working on this, I think can also be a great communication tool.
Great. Next question. How can healthcare organizations promote a culture of well-being for physicians? And Chris, why don't you go first?
I think it's speaking about this on a regular basis, providing the resources around it. When we identify physician, it starts with the culture of the organization, but it's also the physician cultures. Physicians are supposed to have all the answers to all the questions, but what physicians' needs are, their needs are specifically different from the general employees of the organization. So make sure we have wraparound services when physicians have burnout, making people aware of them. Not that we need to be experts in everything, but the medical staff leaders, the MEC leaders, they all need to be able to recognize that there's concerns or physicians are struggling. Assume good intent. It's not, oh, there's a lack of professionalism. Now, what's wrong with you? It's, hey, how are you doing? Is something going on? It's compassion with accountability is how we try to focus here.
And Sapna.
It's showing that you're invested as an organization. So the investment being in, promoting people into positions where they're dedicated to the work of well-being, and ensuring that you're, investing resources into places where we can actually start to fundamentally make changes happen. And then living it. I think it's really important. There's a culture in medicine of competition for being busy or being, the doctor who's seeing the most, staying the latest, not taking days off. It's fundamentally a part of how we were kind of trained. And I think that what's important is when you begin to live that culture. So I'm not expecting you to check your inbox on your days off. I'm not sending you emails after work hours. I'm trying to figure out how to offload things that you're not having to do on Saturdays and Sundays, which are traditionally, you're not on call, you shouldn't be taking care of that. There are things that we have to show from the leadership level down, and even just as mentors to the younger generation. There is a shift generationally in what people are expecting in terms of work-life balance and what well-being is defined as for different groups of people. But I think at the end of the day, living it and being an example, a role model of what that means, drawing boundaries, and then respecting others when they draw theirs is really, really important, because that's the culture. Then that becomes the lived culture and the lived reality for your physicians.
And how do you model that behavior as a leader?
Fundamentally, I think it's being open to offering people help and planting those ideas when they need it. When you see somebody struggling, the question isn't, just here's the number for EAP, let me know. It's, I'm going to give you some time off so you can go take care of this, and anything else that you need resource-wise, we're here to help you. If you don't want to reach within the system, we have resources outside the system. We work with private psychiatrists, private therapists, so that physicians who fundamentally still feel a little bit hesitant about getting that help within the system can reach out. And like I said, just being very respectful of the fact that, I, as the CMO of our organization, am still holding on to the title of Medical Director of Physician Wellness. Those two roles don't fundamentally live together in most organizations, because the thought is I would prioritize the physician's voice over anything else that the organization would need. And I think what is really important is this message is to our entire organization. We think all of those responsibilities are important and that they can be prioritized in a way where we're respecting everyone's voice at the table. So I think that's one way as a leader for me to continue to hold that role and title that I've tried to show our investment.
Jim?
Yeah, I mean, we've touched on this a few different ways. I would just highlight, I think the key thing here is to address more than just personal well-being. Burnout doesn't start within physicians, it just shows up in physicians. And so I think, again, what our other panelists have talked about is, looking at efficiency of work. And I think a lot of that has to be educating your frontline leaders or anybody who has a position of influence over other physicians. Educate them on not only how to identify, but how to address some of the administrative tasks that don't need to be there, and so that they can lead making those changes and reducing some of that work from the physicians that they manage.
And Nigel.
Yeah, some of the things I think that have worked for us, we've talked about in earlier questions. So the importance of executive sponsorship, talking about well-being as a quality indicator, if not the leading quality indicator. The fact that, if you're interested in patient experience, you have to be interested in well-being. It drives quality and safety outcomes. It drives, discretionary efforts, things like that. There also has to be shared accountability. So well-being is part of our executive goal grid. I have the same goals as our CFO and as our chief operating officer. And, there's a people bundle within that. So I think that creates alignment. And then I think as Sapna touched on earlier, reporting out to the board of directors. So that sort of expectation that you're accountable to the board of directors, I think helps with this.
Anything else to say about accountability? I think that's an interesting question when it comes to a culture of well-being. Anybody have anything to add on that?
I always like to go back to compassion with accountability, right? But we all have a job to do, and we're expected to be at our best all the time. But we don't know what's going on in someone's life, whether personally, professionally. So when we're looking at well-being, we need to take a step back, take the whole picture into account, and also train our leaders to be able to do that. It's not that, you had an infection here, or you yelled at a nurse there. You will be, people are accountable, but we also want to make sure there's not something underlying else going on that we can address. Number one, systematically. We talked about processes that are broken, or administrative burdens. Those need to be addressed, of course, and that's how we dig down into the weeds and fix those things. But accountability is an important. We're physicians. Accountability is critical to what we do, but compassion is also critical.
Yeah, I'll just add, it has to be a part of department meetings on the agenda in the same way that, the finances are talked about, patient experience is talked about. There has to be some sense of ownership, at the level of the units, as well as within the executive team.
Excellent. Next question. What are the primary approaches to enhancing ease of practice for physicians? And Sapna, why don't you go first?
I think it's really understanding fundamentally what are the pebbles in the shoes that I think people run into on a daily basis, in addition to what are the larger systemic drivers of inefficiency. I think that many of these things over time were intended to help physicians and intended to help make healthcare more efficient, at least more, functional and collaborative. And technology is a place that I would say you can look to that. Initially, I think the intention was to drive efficiencies, but over time, I think a lot of physicians will tell you has also contributed significantly to their burnout. So for example, the movement from paper charts to the electronic medical record intended to really kind of help put things in one place, create a chart that was all access, everything's in one place for not just the physician, but the patient to access as well. But over time, a lot of physicians will tell you they feel like database entry clerks. They feel like they're just typing in information, and they're not sure that they can see how that enhances the quality or the efficiency of the work that they're doing with the patient. Now, the flip side of that is, let's take that same technology and find a way to leverage that so that we can make things a little bit easier. And I think with the advent of AI in particular, and the ambient scribes that are out there being integrated into these electronic medical records, we are finding that some of the inefficiencies that existed as a result of that technology can now actually be offloaded. So you don't have to be typing away and clicking away while you're speaking to your patient. You can hold their hand. You can look them in the eye when you're having a difficult conversation. And being able to just be able to rapidly close charts, place orders, things that fundamentally help you move from one visit to the next. I think that those are the things that you have to look at in terms of your strategy is, what are the things that are fundamentally slowing us down and making things really hard? And then how do we leverage either technology or your staff as well? And making sure that people are working to the top of their license when it comes to what their capabilities are, so that it's not just being dumped on the physician to take care of everything. There are many, many people in the clinic, front and back office staff, that could potentially contribute to that work as well, and help to offload some of that.
Jim?
Yeah, Chris, I'd say I think, systems have to get gross. Get rid of the stupid stuff. And really look at reducing some of that low value work that a physician doesn't need to be doing. We at the AMA actually have a free resource. So I feel comfortable mentioning that, our Saving Time Playbook, which is in our AMA Steps Forward catalog. I recommend people take a look at that. There's some great learning opportunities in there on how to do that. I know Dr. Singh brought up, ambient listening. That's important. I think also just looking at some of the required educations that physicians have to meet now. That's a tremendous amount of work. We're actually working with a few systems now to help them through an educational program curate catalogs of courses so that physicians can more easily go in and meet some of their CME requirements. So I think that's another thing that groups should take a look at.
Nigel.
Yeah, I'll just make the comment that I think the science of practice efficiency is a little more advanced in the ambulatory setting than the hospital-based specialties. But as others mentioned, it's combining low-tech solutions like workflow redesign that promote top-of-license work, but also high-tech solutions. And a lot of these are AI-assisted, whether it's ambient listening. But it's not just documentation. You have to look at everything that physicians are doing on the computer. Clinical review, we're piloting a AI-assisted tool that can do chart review, so that when a physician goes in to see the patient, you'll have a 2-paragraph summary of what's happened to the patient since you last saw them, rather than having to mine through millions of notes. It's AI assistance with patient messaging. So it's really just a combination of things. But you can't just be one and done with documentation. You have to look at everything that the physicians are doing on their computer, get them off the computer, get them looking at their family, or get them looking at their colleagues, and most importantly, have them looking at their patients.
Chris.
Yeah, I agree with all my panelists. I think in healthcare, we're really good at adding things and tasks and administrative things to physicians and nurses and our colleagues. We're not good at taking them away. So it's always having the question, does this add value? Should we still be doing this? It may have made sense 5 years ago, 10 years ago, but does it still make sense? Does it still add value? Always having that questioning attitude. And then lastly, check with your EMRs. I know it's not just about documentation. There's a lot of things that clinicians and physicians are on their EMRs for. But within a lot of the EMRs, we're an Epic shop here. There's a function in there called Signal to see where are the opportunities for our physicians? Where are the inefficiencies? Targeting your areas that our physicians may be really struggling with, or they're not raising their hand. we can really impact their lives by just some little tweaks or some education or at the elbow support.
And give me an example of an inefficiency in the EHR that you can address to help lower the EHR burden on physicians.
Sure. We were just looking at something for inpatients, how many clicks it takes to order something, where it's taking maybe 5 clicks to do it. And because you don't have things set up right, we could streamline it so it's just 1 click. Or, if you don't have your templated notes set up the right way or your orders streamlined the right way, instead of, typing a whole note in, or, hopefully you're using ambient listening, or you will be soon, other efficiencies that have pre-templated notes that can help pull in the data.
Any other suggestions on EHR optimization before we move on? Okay, let's move to the next.
Little things that add up.
Right.
As I think Chris was mentioning, when you're putting in orders, when we're ordering MRIs, we were asking our physicians a bunch of questions that the EHR should already know. So, removing clicks, unnecessary clicks when you're doing orders.
Great. Next question. How can healthcare organizations support the mental health needs of physicians? And Jim, why don't you start us off?
Yeah, I think we've tackled this a few different ways. I think I would just add on some of the things I said earlier is eliminate barriers. And part of that is making sure that physicians have the access to time off to even attend therapy or to seek mental health. That is not as easy as it sounds for a very busy physician. Making sure that they have confidential referrals. And then again, we talked about this with some of the invasive questions on credentialing applications, but just make sure that they know there's no career penalties if and when they do seek help.
Nigel?
Yeah, we covered some of this in one of the previous questions, but I'll just make the observation that, early in the pandemic, we actually saw EAP utilization go down. And what we were hearing when we rounded was, this sense that people wanted to get more upstream. So we have a good EAP program, but how do you vary the support services? So we have, a number of different ways to try and reach our physicians. We have a platform called Cabana where you can actually create an avatar of yourself and disguise your voice and enroll in, group therapy sessions that are led by a behavioral health specialist, having a robust peer support program. So just making sure that you're thinking more upstream and not just letting things percolate, to the sort of code blue of depression or mental health.
And before we continue, just a program note, I want to encourage the audience to submit questions. You've got the Q&A widget, and let's move on. Chris, what about mental health needs of supporting the mental health needs of physicians?
Yeah, I think, our panelists kind of talked a lot about it. I think, of course, prevention's the key, right? Promotional wellness. But when it does happen, again, training our physician leaders to recognize, because a lot of times it goes unrecognized, undiagnosed, or, someone's just a little bit more quiet than they usually are, or there's a bad case, but no one, don't have the debrief. Or, when people are acting out, why are they acting out? So really working with your MECs, your department chairs, your section chiefs, every healthcare leader across it, and really helping them recognize it, speak about it in their department. I think the awareness is so critical to that. But also when we do recognize, reaching out to the clinician, connecting them to the support or someone who could provide additional resources, but making sure it's confidential, building that trust that this is a confidential process, it's a protected process, and we're here to support you. The confidentiality is going to be critical to physicians seeking help.
And Sapna?
Yeah, not a whole lot more to add. I think everybody's really kind of touched on it. I think, fundamentally, it's just being able to meet physicians in all the different places that they need that help, whether it's internally within the system, if they're asking for help outside the system, because they don't necessarily want to speak to anyone, within the organization, despite all the reassurances of confidentiality. And then obviously, yes, like being thoughtful about the fact that there's time involved and there's time away from their clinical duties to go do this for themselves. So that may mean that we've got to make some workarounds for their schedules. We've got to provide them with the ability to take time off and to allow them to build into their vocabulary asking for the time off when they need that for this purpose. It's interesting because there is an entire generation growing up now with mental health days as something they are allowed to ask for and step away from work or school for. Not all of us grew up with that. And so I think that fundamentally is difficult for some of us to ask for. I know I need to stay home when I have a 104 fever, but do I know that I need to stay home because I am so overwhelmed with things in my personal life or at work that I just need a break? I need a 24-hour, 48-hour break, maybe a week. But asking and giving people room to ask and allowing them to have permission to ask is also really important in terms of allowing them to get those resources.
Chris, I was just thinking of something I learned from Mark Greenewald out of Carillion Clinic. I remember him sharing the story, and that's with mental health, we talked about a lot of the barriers to physicians asking for help, but physicians aren't also people who often want to ask for help. And so Dr. Greenewald gives a lot of great advice about creating a peer program that isn't just built around a bad outcome, where they routinely have a peer that they meet with and have dialogue with. So it becomes more of a routine so that when there is a bad case or a bad outcome, they'll be more comfortable with maybe talking about that with their peer. I always thought that was a really interesting insight.
Yeah, I think that's a great point, Jim. We also developed a peer support program where physicians can reach out to, and it's been used probably about 8 to 10 times since we launched it about 8 months ago, and it's been a success is from what we can see. The other thing that we're looking at is it a peer support or a mentor? We have clinician coaches, but we're really looking at that's really their mentors. People can reach out to get that support or at least find different avenues. That's a great point.
Well, I know we've got a couple more questions here on the list. Let's move into the Q&A portion of the program. First of all, thank you all for excellent discussion. We would now like to invite you in the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. And as we're waiting for some questions to come in, one thing I'd really like to get to is what are 1 or 2 key takeaways from this discussion that you would like the audience to be able to latch onto? And Nigel, why don't you start us off?
Yeah, 2 things, I guess, is resourcing and commitment to resourcing. It's sort of fantastical to think that an Office of Professional Wellbeing comprised of 7 FTEs can be responsible for the well-being of 40,000 employees. So there has to be shared accountability and different ways to do that.
And talk to me a little bit more about shared accountability. I mean, how do you've got your wellness office with a half a dozen people in it. Who should that shared accountability spread out to?
Well, we sort of talked a little about this, but you'd hate to say it's part of the compensation plan, but for our executives and leaders, it's a small component of their compensation. It has to be operationalized, so it has to be part of the quarterly operating reviews. It has to be part of department meetings. There have to be regional discussions. So at every layer of the organization, it's a subject that's discussed and leaders are accountable for.
Chris?
I think the commitment, to the initiative and the importance of it, the awareness, but also the commitment to take action. Talk's cheap, and really addressing those initiatives again. Even if you address for a year, get that low-hanging fruit and keep working. It's a journey; it's not a destination. And the last thing is, I think it's physician to physician. I think when physicians set the example, show some vulnerability, show their stories, tell their stories, it really goes a long way and spreads the culture.
Sapna.
I think a takeaway for me, it's just the idea that we have to prioritize this. This is no longer some kind of an optional program or some sort of a, one-off that we can put to the side and check off a list of things that we are participating in. I think that when you talk about physician wellness and employee wellness across the board, this is fundamentally as important as the word quality was back in the 90s. Now we're moving into systems where a majority of the physicians are not independent, they're working for organizations, and how do they continue to hold value and feel valued within the construct of this new landscape really in healthcare. I don't see us moving away from that. And so now what we need to do is make sure that the systems are working for everybody. And so I would say that at this time, the discussion has to move past just a small committee that's having a discussion every couple of months about how do we, bring a small party to a clinic, and really fundamentally move into, like I said before, our leadership teams, our boardrooms, and fundamentally, like many of the panelists here said, make it a part of all the discussions when it comes to decision making. It's as important as the finances. It does contribute to quality and safety. It does contribute to the financial well-being of an organization. And at the end of the day, the individuals, when they feel cared for, they're able to contribute and care back. So I think that we really just have to be thoughtful about, this isn't a sidebar anymore. This is really an issue that has to be tackled. And I hope that everybody takes it as seriously as I think it needs to be.
And Jim.
Yeah, I just would hope that anybody who has an opportunity to listen to this follows the lead of the three other panelists on this, and remove the burden from individual physicians on solving their sense of burnout, and instead look upstream at the systemic root causes that is generating that burnout in their physicians, and start there.
And how do you shift that? How do you shift from, the burden of burnout being on the individual to looking more at system level issues?
Well, I think you start with measurement because that's where you can identify just the level of burnout across your physician workforce, but also start to identify what's driving it. But I would leave it to the other leaders on this call to answer that last part of that question.
Anybody want to tackle that?
Well, we talk about the canary in the coal mine. So, before the pandemic, as I said, I didn't want to talk about resilience and mental health because I didn't want our physicians to think it was all about sleeping better, eating better, doing yoga, that it was fundamentally around systems that drive burnout. So it can't be just about building stronger canaries, it's about redesigning the coal mine.
And I would speak to shared accountability. I think that came up multiple times, and it's the idea that everyone has a voice, but everybody also has responsibility for making sure that the actions are taken and that we are assessing what the needs are, but really that it's not just left to one small group of people or a person. This becomes the culture of how everyone leads and how everybody lays eyes on this issue.
That's
one thing I don't think was, oh, sorry.
Go ahead.
Right. No, I think one thing that wasn't covered was the importance of project management. You need, engineers who are able to build a charter, scope a project to move things forward. So we've been lucky to have, a team of project managers that help us.
And that's all the time we have for questions today. In closing, please note that our next Winning Edge program on December 2 will cover the Winning Edge for achieving strategic growth across service lines. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage on strategies for battling the burnout by visiting our website, healthleadersmedia.com. I want to thank our panelists once again for an excellent discussion and our sponsor, AMA, for making today's program possible. And finally, thank you to you and our audience for participating. We hope you enjoyed today's program and look forward to seeing you during our next Winning Edge program on achieving strategic growth across service lines.